Dear Paul, thanks for the friendly introduction. So today I will speak about the use of contrast lens ultrasound in vascular imaging. First of all, I will give you a short notice regarding application. Then I will speak about the carotid artery, the aorta, peripheral vessels, some microvascular interventions, and finally I'll give you a short conclusion. So if you would like to inject sonogram, there is a need to inform your patient, and the patient have to give an informed consent. This contrast agent have no impact on kidney and thyroid function, and the dose you have to inject is depending on the organ and the frequency and type of probe you're using. For example, for the carotid artery, the amount of contrast you should inject is around about 2.4 cc followed by 10 cc. And if you look for aorta, it's roughly about 1 cc of contrast. Starting with the aorta, we know there's some couple of risk factors for developing strokes, like atherosclerotic stenosis, preocclusive stenosis, plaques, dissections, blood pressure, smoking, and some other facts which have got an influence for developing strokes. So every examination in the contrast examination start with a fundamental grayscale. So we see the bulb, we see the common carotid artery, the external carotid artery, internal carotid artery. Now we repeat the same examination by looking at the color Doppler and power Doppler setting. We see some small tiny branch from the external carotid artery. And we also see that this technique is depending on the scanning angle and on the velocity of the flow. If we repeat the same examination with contrast, we see the microbubbles arrive, we see a nice filling, we see the internal carotid artery, we see a plaque here also, and we see also a little bit later that the jugular vein show a filling afterwards. So we see also soft plaques here at the wall, so no overlay technique. We see also these tiny stenosis in this area, and it gives you a higher resolution, and it's not so depending on the scanning angle. Another case also, again, we look at this kind of plaque. It's a mixed plaque with some calcification, also some soft plaques inside. Also, if we repeat the examination with contrast, we see, first of all, the patient has some problem with the heart because the contrast arrived, first of all, in the jugular vein. Then we see later a nice enhancement of the carotid artery, that's the common carotid artery with some plaques. And also, if we look at the axial plane, we see this hard plaque and soft plaque. In this case, we show only a little bit tiny uptake in the plaque for contrast, not major contrast uptake. This uptake is not visible by looking at color Doppler or power Doppler technique. In this case, everybody of us see that the stenosis. This patient have got a major soft plaque here at the bulb. We see also some aliasing at the color Doppler settings. If we repeat the examination again, we see the complete extent of the stenosis. This stenosis has got a length around about 2 centimeters. It's very important to write in the report. And the question is a concentric or eccentric stenosis. Also, this is very easy to repeat because you see it's at the wall of the plaque. So it's an eccentric stenosis. And these are the plaques we have seen also on the longitudinal plane. The recommendation from the EFSUMB guidelines is that contrast-enhanced ultrasound could be very helpful to make a differentiation between total occlusion or partial occlusion because it could show even residual flow in a tiny stenosis. It's also helpful for the evaluation of plaques and also for better enhancement of the vertebral arteries and also of the aorta. An aneurysm of the aorta is called aneurysm if the diameter is more than 3 centimeters. In the Western nation, we have got a higher risk in comparison to other areas of the world. 60% of these aneurysms are asymptomatic. That's the reason why the patient don't know that they have got an aneurysm. Unfortunately, most of the patients are men, and there are a couple of risk factors that they could rupture. For example, if the diameter is growing, they have to care about. This is the reason why patient in Germany with an aneurysm diameter more than 5 centimeters will be treated often with the endovascular repair. So starting with the grayscale, looking at the Doppler, we see this aneurysm. This aneurysm has some tiny calcification at the wall. The question is, why could we not see the complete enhancement Doppler inside? Is the flow so low or is there no flow? If we compare or repeat the examination with contrast, we see a couple of tiny bubbles appear. We see that this is a huge aneurysm with thrombotic changes, but you see now it's inside completely filled and there's also a small branch leaving the vessel. If we look at this kind of MIP reconstruction, we see the complete flow inside much better in comparison to previous examination I have shown you. If a patient has got a dissection, often we have to ask the question, what about the perfusion of the true, of the fourth lumen? Where is the true, where is the fourth lumen? What about the perfusion of the adjacent organ? So in this case, we see that this is a kind of fusion technique. We see this is the aorta, this is the supramesenteric artery, and it seems to be that this artery has got a dissection in the CT. In the conventional grayscale, we could not see clearly dissection, and if we repeat the examination by looking at the Doppler, even here it's not very clear to see it. It seems to be that in this area of the Doppler is a less flow in comparison to this, but probably it's not clear whether the patient has still dissection or not. If we repeat the examination, we see there the enhancement of the true lumen, split Bateman at the enhancement of the fourth lumen. This is a really rare case because it's an isolated dissection of the supramesenteric artery and it doesn't involve the aorta. You see pretty nice, there's the dissection. It's much easier to see, and in the fusion technique you see that these match pretty good the same with the CT. We have also the option to look for the flush that you see enhancement in the true lumen, fourth lumen. So we could still describe that the dissection is still existing, the flap still is existing, and both lumens show a pure fusion and there is no stenosis inside. Also look at this organ. There's the aorta, but we see just adjacent on the left side where normally IVC is. We could not find any flow by looking at the color Doppler. The question is it a thrombus or the tumor thrombus? Then we inject contrast to see the filling of the aorta, but we still see that there is no bubbles inside. And even if we look in the longitudinal plane, we see at the cranial part of the IVC flow, but here it's a fresh thrombus on the IVC. Due to the fact that this thrombus shows no contrast uptake, we can say it's only a thrombus. It's not a tumor infiltration, not a tumor thrombus. Most of the aortic pathologies will be treated with endovascular repair. So if you think about this aortic graft, there could be complication. You could divide it either in the early period, that means weeks and months, the hematoma, infection, endoleaks, or in the late period, there could be endoleaks, occlusion, or dislocation of the stents. So if you speak about the endoleaks, because these are the most difficult cases, we could divide it into 3 groups, type 1, type 2, type 3. The most common endoleak that's called type 2. Due to the fact that it has got only low flow, it's only called a low flow endoleak. It's a follow-up needed only if there's a growing of the aneurysm you have to treat. Type 1 and type 3 will be called high flow endoleak. That's a high pressure inside. This means the patient have to go on treatment very soon. So if you now look at the grayscale, you see the aorta, you see the 2 branches of the stent graft. We see some coloring in this area. Is this now a leak over the IMA or what else? If we inject contrast, there is no contrast inside. This is just an artifact from the air. Also in the longitudinal plane, you can say in Doppler it looks like an IMA endoleak, but contrast ultrasound could exclude any leaks. Another patient also with a stent graft, if you have got less experience, you can say this could be a vessel, but if you have experience, you will say this is a kind of twinkling artifact. The perfusion of the stent graft seems to be fine, so normally we will not expect any leak in this case. So by looking at the contrast, you see a nice filling of both legs of the stent graft as we've seen it here. And if we go to the later phase, we see a nice enhancement of the thrombotic aneurysm. And the feeding vessel in this case is the left lumbar artery. Also, it's called a type 2A endoleak because it's only one feeding vessel. Another case also, we look at this aneurysm. The aneurysm has got only a diameter around about 3 centimeters. By color Doppler, everything looks fine. Normally, we will say there's no leak, but if you repeat the examination, you see an enhancement of the stent graft, everything's fine. And then you have to care in this area. There you see a couple of bubbles here in this area. Also, if you flash the bubbles are gone and come back. So it's a type 2A endoleak, and the feeding vessel is the IMA. What about the sensitivity and specificity? There's a couple of studies which compare contrast and ultrasound in comparison to CEUS, and all the studies shown that the sensitivity and specificity could be increased if you're using these techniques in comparison if you only use contrast-enhanced, if you only use color Doppler examination. To my personal experience, probably you will miss around about 25% of the leaks if you stop by color Doppler examination. What are the take-home points? Endoleaks could appear anywhere and at any time. Type 1 needed to treat it immediately. Type 2, you have to watch and wait. It's important to know what is the feeding vessel. If you speak about a type 2 leak, it's the lumbar artery or the IMA, a different pathway of treatment. The patient have to go under follow-up for the end of their life. And to our experience, contrast ultrasound is more sensitive in comparison to CT in detection of leaks. This is also recommended by the EFSUMB guidelines. Now we switch to the peripheral vessels. This is the femoral artery. We see some flow by looking at the color Doppler. We see a couple of calcification. The patient had got pain in the leg. By looking at contrast and ultrasound, you see this is the vessel. Then you see an occlusion in this area. Then you see kind of collateral vessels here. So it's a short occlusion of the common femoral artery as we detected here. What about this patient? This patient has got a shunt, and we see this is the PFT shunt here. Color Doppler, a power Doppler could not see any flow inside. So is this occlusion of the shunt, or is the flow only very slow? If we repeat the examination, you could see it's a complete occlusion of the shunt. Also in the later phase, complete occlusion of the shunt. So the patient have to go under intervention of this shunt. What about deep vein thrombosis? There you see a vessel, which is an enlargement. It shows hypergenic trough inside, only some small flow inside. If you repeat the examination with contrast, you see a revascularization of the thrombus. So it's a thrombus of the vein with some partial revascularization, but most of the thrombus also include the complete vessel as we've seen it here. Also here you could see this is part of vascularization inside, but the contrast stocked inside. And then we see a tiny bubbles show up also here in this part of the thrombus of the deep vein thrombus. My last part will be treatments of options of treatments of uterine fibroma. So either you will see and wait. There could be medications, or there's also an option that you can use HIFU, MRI guided, for minimizing this kind of myoma. So if we look at the beginning, we see a huge myoma there. We see there the myoma there. We see the color Doppler inside. We see also part of the iliac arteries on the right, on the left side. Then we repeat the examination. Also, we see the myoma in the MRI. There's the myoma also in the grayscale, so that matched pretty good. And then we inject contrast. We see a nice perfusion of the myoma, same as we see it in the MRI. This was pre-treatment, and of course, we would like to follow the examination after treatment. So you see some liquid here, but in the color Doppler, it looks very similar as we've seen it in the previous examination. Also, you see this match pretty good, but you see in the enhanced NMR that there is a part of areas where we show less contrast uptake of the myoma. Will this also fit with our contrast examination? So we inject contrast and you see a couple of necrosis inside in this area, for example, where in the past examination you see a nice perfusion. Also here you see a very good treatment of the myoma guided by HIFU therapy and controlled by contrast and ultrasound. What are the take-home points for you? So probably I could show you that Sonography is very helpful for most of the vascular pathologies. It gives you additional information regarding perfusion, and it has no dependence on the scanning angle and is no overlaying technique. Also, there's the option to detect slow and fast flow at the same time, and of course, it's available everywhere and save costs. So CEUS is very important compared to other imaging technique because it has no radiation and no nephrotoxic effects. It could be implemented in your daily workflow very easy, and there's an increased perception of clinical value of CEUS which be reflected in scientific papers and guidelines. I would like to thank you for your attention.
Okay, I think you can hear me.
Yes.
Yeah, thank you very much, Dirk, for that very clear overview of the vascular uses of contrast-enhanced ultrasound. It's very important that the audience also realizes that the imaging you were showing is very wonderful images, but it's also this really good resolution, and you're showing images down to in those veins to 1, 2, maybe 3 millimeters. And this shows the use of contrast in as a problem-solving tool. You pick the one area, you put your probe on, and you have a diagnosis of a 2 millimeter area.
Immediately.
Yeah, and I think this is the important, as you said, important take-home point is it's a practical problem-solving tool. I know that in the EVARs that you've been doing, I think you've told me once that you actually did a whole EVAR under contrast-enhanced ultrasound guidance.
Yes.
Is this correct?
That's correct. In the operations theater, yeah.
Yeah. So this was very useful because if the patient has renal failure or renal impairment, you're not subjecting them to quite a lot of amount of iodinated contrast and renal impairment. But it's not the first thing that our audience should start with, for sure. Okay, I have no other questions from the audience, and I want to thank you very much for that presentation. And I see now you've got a course coming up in Munich in October. So anyone wanting to visit Munich, you will have missed the Beer Festival, of course, but there are other things going on in Munich. And the course is very comprehensive and serves everyone who wishes to go. Really, you'll be very well placed for that. Thank you very much.
Thanks.